So hi guys, welcome everyone to the method. We are continuing our Read Harrison series, and in this topic we will be talking about chest pain. A very important and in fact an extremely crucial topic for the today's generation medicos, because chest pain is still a symptom which is feared by patients as well as doctors. Patients fear because what if I am having a cardiac chest pain, and doctors also fear what if I miss a cardiac chest pain. And it is still a common scenario. Many times patients with chest pain come to the emergency room. The emergency room doctor or the JR examines the patient, does some basic investigations including ECG, and then he concludes that this is probably a simple case of gastritis, gives a pantoprazole injection, prescribes a PPI and sends him home. And then after a few minutes the patient comes back, but this time in more grave situation, and now the ECG starts showing classical findings of an ST elevation MI. So what happened? We just missed the early recognition of a acute coronary syndrome or an MI. And this is still a common scenario, right? Nowadays it keeps happening. And nowadays it is not just the patient who comes back to the emergency room with a more grave condition, but when you fail to recognize acute coronary syndrome in the emergency room and send the patient home, along with the patient when it is returning, you see a crowd which comes and then ransacks the hospital, assaults the staff. It's a common scenario, right? So we should not be missing out on recognizing cardiac chest pain patients. So what we will do is we will just take one quick simple example. So here I have jotted down the stories of two patients who have acute onset chest pain. We have on one side patient A who has retrosternal chest pain, means chest pain almost central behind the sternum, which is very sharp and stabbing in nature. And on the other side we have patient B who has retrosternal chest pain, which is diffuse, not sharp, pinpointing somewhere, and then it is squeezing in nature. Now my question to you is, between patient A and B, again let me remind you, patient A has very sharp retrosternal stabbing type of chest pain, and patient B has retrosternal pain which is more of squeezing in nature, not very sharp. Between these two patients, whom do you think is likely to be having a myocardial ischemia? Yakin, I have not much idea about the NEET because I have not followed the NEET. I am primarily teaching the NEET PG students. So NEET PG is just around the corner. Means it was scheduled, they have postponed it. Okay, so I get one answer that probably patient A is the one who is a case of cardiac chest pain. I also get one more answer, probably patient B is a case of cardiac chest pain. For some time, ignore these two patients. I will tell you one more patient story, right? I have patient C and patient D. This patient C has retrosternal chest pain, which is referred to the right shoulder. Retrosternal chest pain, which is getting referred to or radiating to right shoulder. And I have another patient who has got retrosternal chest pain, acute in onset, which is getting referred to the left shoulder. Now between C and D, whom do you think is a case of cardiac origin or angina or ischemic origin chest pain? Is it C or D? What do you think? Between C and D, patient C has got chest pain which is retrosternal, acute in onset, which is getting referred to right shoulder. Patient D has chest pain which is retrosternal, which is getting referred to the left shoulder. Okay, so Medlad thinks option C and Anshuman thinks option D. So now we are getting answers in both the sides, right? So what does that mean? It means that we still have some more insights to derive in chest pain to be able to recognize the patients with cardiac chest pain more efficiently. Okay, so for that let me take you through one small table in the Harrison. Okay, so this is a table in the Harrison which shows symptoms associated with the chest pain and their likelihood of being a acute MI. Okay, so first thing, when you look at this graph, right, what do we understand? The topmost associated symptom has the highest likelihood of being a case of acute MI. And what is that symptom? Radiation of the chest pain to right arm or the shoulder. See, this is one common scenario in the emergency rooms today in India. Whenever you go to the emergency rooms with chest pain, the staff nurse or the junior doctor there, they will ask you, does this chest pain radiate to your left shoulder? And the moment patient says, no, it is not radiating or it is not getting referred to my left shoulder, right? The staff nurse or the duty doctor takes a sigh of relief and then start thinking this is not a cardiac chest pain. A big blunder or a mistake. So studies have shown that the chest pain of myocardial origin can be referred to either of your shoulders or either of your arms. It can also be radiated to or referred to your jaws, neck, oral cavity, tip of the tongue, epigastric. So merely by taking this history that the chest pain radiating to the left shoulder and left arm is suggestive of cardiac origin and everything else is unlikely to be cardiac origin is the first thing that we need to unlearn from our current understanding. Chest pain of myocardial ischemia, position wise, yes, it is retrosternal, but it can be referred to both the shoulders, right? So look at the second high possibility of ischemia, that is radiation to both arms and shoulders, right? Radiation to left arm has relatively lower likelihood of being an acute MI than the radiation to the right arm. So first point that we learned today is that the chest pain of acute MI or myocardial origin chest pain can be referred to both shoulders, both arms, neck, jaw, right? Oral cavity, tip of the tongue, epigastrium. Anywhere it can be referred to. Clear? So what we will do now is we will try to understand the approach to a patient with chest pain. Let me give you a basic answer for this. We will revisit this point. The patient A is less likely to be a case of acute MI or a cardiogenic chest pain. It is patient B who is more likely to be a case of cardiogenic chest pain. Patient A has less chances of having a cardiac pathology. Patient B has a higher chance of having an MI. Right? So whenever we have ischemia of the myocardium, whatever chest pain we develop, we call it as angina. So first thing we will do is we will understand angina. But before I take you through angina, Harrison gives you a small pie chart of different causes which can present as acute chest pain. And when we look at that, the most common cause is gastrointestinal. Means when you have gastritis, peptic ulcers, duodenal ulcers, right? Gastric ulcer, duodenal ulcer, or gastritis or gastroenteritis that can cause chest pain. We are not much worried about them, right? What is my biggest worry? I do not want to miss out a cardiac chest pain. And unfortunately they rank second. So if I see 10 patients coming to hospital with acute chest pain, right, almost 1/3 or 30% of them out of 3 patients coming with chest pain to the emergency room, at least one of them will have angina, right? Okay, so what we will do is we will be aware of the list: gastrointestinal causes, ischemic heart disease, chest wall syndrome means when you have the ribs or the intercostal muscles or the cartilages, if they have some pathology. Pericarditis can cause chest pain. Pleural inflammation or pleuritis can cause chest pain. Pulmonary embolism can cause chest pain. Aortic stenosis, aortic aneurysm, these are all differential diagnoses, but my biggest concern is the ischemic heart disease. So when someone has ischemic heart disease, the kind of pain he develops is angina. So we call it as angina pectoris. What is angina pectoris? It refers to chest pain due to myocardial ischemia. Chest pain due to myocardial ischemia. So once we understand the nature of this chest pain, we will be able to understand how to differentiate a patient with ischemic heart disease and having chest pain from all other causes that are listed here. And whenever we describe pain, how do we describe the site, right? The site or the origin of the chest pain, and then the nature of the chest pain, intensity or severity of the chest pain, and to what all structures the pain is getting referred to or getting radiated to, and what are the aggravating and relieving factors. This is a common template of describing any pain, whether it is joint pain, chest pain, any pain. Same template we will follow here for the angina pectoris. So if a patient has chest pain which is because of myocardial ischemia, in terms of site, the pain is going to be located retrosternal. And when I say retrosternal, it means almost centralized. Again, one of the common mistakes that undergraduate students do is thinking that heart is more of positioned on the left side, so the pain is going to be on the left side of the heart. No, the pain is going to be more or less centralized. That's why we call it as retrosternal chest pain. Behind the sternum, patient feels the pain. What is the nature of the anginal chest pain? It is usually constricting, pressing or squeezing type. Means the patient says that it feels like the chest is becoming heavy, especially in the center part, or he says that it feels like someone is squeezing my chest inside, or it feels like the chest, something is pressing my chest. So that kind of heaviness, constricting quality or squeezing is the nature of the chest pain. So whenever I think of a retrosternal chest pain, which is sharp stabbing, it is unlikely to be because of ischemia. Clear? So I'm more worried of a patient who says that the pain is kind of heaviness rather than someone who says that कि हाँ खंजर घुसने जैसा feel हो रहा है. It's unlikely to be ischemic origin if it is a sharp and stabbing kind of chest pain. What can cause a sharp stabbing retrosternal chest pain? If I have acute pericarditis, or if I have some acute pathology of the esophagus like esophageal mucosal injury, what you call as Mallory-Weiss tear, or if I have the perforation of the esophagus, what you call as Boerhaave syndrome, or if I have the pleuritis, pericarditis, pleuritis, Mallory-Weiss syndrome and Boerhaave syndrome. These are the conditions where I can have sharp stabbing or penetrating type of retrosternal chest pain. In case of ischemic heart disease, what we call as angina, the chest pain will be most likely described as heaviness, squeezing, constricting or pressing type. Now where can it get referred to or radiated to? It can get radiated to both shoulders and arms. Please remove from your mind that the pain that is referred to left shoulder and left arm is of ischemic origin. Pain that is referred to shoulders, both the shoulders, any shoulder is likely to be myocardial in origin. It can also be referred to neck, jaw as well as the epigastrium. So these are all the places where this pain can be referred to. Usually, if it is an anginal chest pain, it will have certain aggravating or relieving factors. What are those? When I say ischemia, what does that mean? Your myocardium requires some amount of blood supply and it is not getting that much. That is what ischemia means, right? So obviously, if I create if I have myocardium, that let me say this is my myocardium, it requires some amount of blood consistently, constantly, and that is supplied by the coronaries, right? So myocardium has a demand. Every second I need this much of blood supply. Coronaries have, based on their size, they will be able to give that supply. As long as coronaries give how much the myocardium wants, there is no ischemia. But if there is a mismatch between the demand and supply, either myocardial demand increases or the coronary supply decreases. In both cases, what happens? There is a mismatch. In what condition coronary supply decreases? Whenever inside a coronary there is a block, critical block, it will not allow the flow of blood, so coronary supply will decrease. In what condition? Coronary supply may be normal, but the myocardial demand increases. An example for that I would quote is when you have myocarditis. What myocarditis means? Myocarditis means inflammation of the myocardium. So when your whole heart muscle is inflamed, it needs more blood supply because all that inflammatory metabolic processes are going on. So they require to burn more calories or more glucose. They need to generate more ATP. So they need more blood supply. You might have heard in the recent times that COVID, many patients who suffered from COVID later developed myocarditis, and because of that they developed myocardial ischemia or MI, and they died also. Why that happened? Because COVID caused mild grade myocarditis. So myocarditis increase their oxygen demand. If the coronaries could not meet that demand, you can end up developing ischemia, not treated, end up developing an infarction, right? Okay. Now, typically what happens, this myocardial demand can also be physiologically increased when we do exertion, right? When we do physical activities, body needs more blood supply, so myocardium needs to work more, so its oxygen demand increases. Similarly, when we are under physical or emotional stress, sympathetic nervous system is activated. Because of that, heart rate increases, myocardial work increases, so its oxygen demand or blood supply demand increases. After heavy meal also, the cardiac output gets diverted to the GIT and less blood flows through the coronary. Again, we can have the imbalance between the demand and supply. So anything that creates an imbalance between the myocardial oxygen demand and what coronaries can supply can precipitate the ischemic chest pain. that can precipitate the ischemic chest pain. So these are the characteristics of anginal chest pain. 3 points to remember here. The pain is retrosternal. In terms of nature, it is constricting, pressing or squeezing type. It can be referred to the shoulders, arms, neck, epigastrium. And it is usually aggravated by, most important thing to remember here is the physical action or exertion. When these features are there, we will call it as angina pectoris. We will call it as angina pectoris. Okay, I have some basic questions to ask. Is it possible for me to physically touch the chest of the patient and precipitate the angina pectoris? See, if I have, let me say, a dislocated joint, right? You press, you will experience tenderness. Will there be any tenderness in a patient who is having the angina? Will there be any tenderness in a patient who is having the angina? No, right? No. So there are 2 points to note here. 2 P's of non-cardiac chest pain. 2 P's of non-cardiac chest pain. What does that mean? The first P is pleuritic type of chest pain. Pleuritic type of chest pain means that it is not likely to be cardiac in origin. And the second P refers to producible chest pain. Producible means by compression or physical stimulus, if you are able to reproduce the chest pain, then it is unlikely to be cardiac origin. So there is no triggerable tenderness if it is an ischemic heart disease or the angina. So if these 2 P's are present, it is most likely non-cardiac chest pain. NCCP stands for non-cardiac chest pain. Okay. In one of the NEET exam, they had given an image of a patient who had come with chest pain and he was holding his clenched fist against the chest, and they had asked, what is this sign? This is a typical sign that we see in patients with angina when they are going through angina episodes, because it is a chest pain which is not sharply localized, it is a bit diffuse and it is more of constricting or a squeezing type. To ease themselves, they generally what they do is they clench their fist, sometimes open arm or the clenched fist, they hold it against the chest. So when you ask them where is the chest pain, they would say this is where I have the chest pain. If I have, like, let me say, costochondritis, the inflammation of the cartilages of the ribs, right, rib cartilages, in that case the patient will pinpoint and show this is where it hurts, and that is a producible pain, means the moment you press it will trigger the pain, right? It is producible and it is pinpointable, right, sharply localized. But patients with ischemia, it can't be sharply localized, so they will show this is where I have the pain or this is where I have the pain. And this sign of a patient with angina holding their clenched fist on the chest, we call it as Levine sign. Levine sign. So in the MCQ they had asked what is this sign called as. Okay. Now patients with angina, sometimes they may not come to you and say that I've got chest pain. Chest pain can be absent sometimes despite having ischemia, because perception of chest pain is a function of the sensory neurons. And patients who have long-standing diabetes, who are at the risk of developing MI, they may have neuropathy. So if they have neuropathy, they may not be able to feel the pain much, right? That is where we say silent MI. But in such patients, when they are going through a myocardial ischemia, it may show up with different symptoms. So we call those symptoms as angina equivalents. Means they indicate that it is suggestive of myocardial ischemia. What are these angina equivalents? These are symptoms of myocardial ischemia other than angina, and it includes dyspnea, fatigue, right, erectations or some kind of chest uneasiness, and diaphoresis or profuse sweating. If these symptoms follow the similarities of the angina pectoris that we described, like the symptoms are usually aggravated on exertion, relieved by rest, then we can consider them as angina equivalents in a patient who has high risk for coronary artery disease, like family history, dyslipidemia, hypertension, diabetes mellitus, right? In such patients, if they present with dyspnea, fatigue or diaphoresis, we should consider them as angina equivalents. They may be because of other causes, I am not denying it at all, but you have to investigate for myocardial ischemia, do the ECG, cardiac troponin. If it all turns out to be normal, think of other causes. If they show up that patient has ischemia, then these are definitely angina equivalents. So far what we have understood, the chest pain of myocardial origin is called as angina pectoris. It is retrosternal. It is more of constricting or squeezing type, diffuse, not sharply localized, and it is usually aggravated by exertion and relieved by rest and sometimes with the help of nitrates. Now, all the patients who have angina, do they have MI? All the patients with MI, all the patients with angina, can I say they have MI? No. Angina is equal to ischemia, means your myocardium is not getting sufficient blood supply. That is the basic meaning. Angina is equal to myocardial ischemia. So whether my myocardium is infarcted or just ischemic, I will have angina. But what is more important for a doctor? The infarction, right? Infarction is a critical medical emergency. Mild ischemia is not a medical emergency. Then how do I distinguish between the infarcted myocardium presenting with angina pectoris and mild ischemia of the myocardium presenting with angina pectoris? That is where this concept of stable and unstable angina comes into picture. Stable and unstable angina. So far we have understood the basic definition of angina. Now we will go a little more deeper and understand what is the difference between stable and unstable angina. To understand the difference, let us think that this is my left ventricle. I have taken a cut section. Anit Kumar, we will be covering it. So let us think that this is the left ventricle, right? So usually this is how the left ventricle would look like, right? Left ventricle, right ventricle. So I have taken a cut section here. So we are looking at the left ventricular wall. So when I look at the left ventricle, the inside what you see in green line is our endocardium, right? Inside this is endocardium. This green line is the endocardium. And this is my myocardium or the cardiac muscle. Okay. Outside this I have the pericardium, and we know that coronaries run on the surface of the myocardium and then penetrate into the myocardium and supply the blood. So let us think that this is a coronary artery. This is a coronary artery. As long as the coronary artery is patent and it is able to supply the blood that myocardium needs, there is no ischemia and no chest pain. Okay. Now let me say that this coronary has got somewhat occluded, and because of that the blood flow to the myocardium has come down. Coronaries are partially occluded, let me say 60%, 70%, there is occlusion, and because of that the blood flow to the myocardium has come down. Now at this point of time, the blood supply may be sufficient enough for the myocardium to maintain the regular activities, means talking, eating, right, walking around, whatever the blood supply myocardium needs, that may be still be available to the myocardium despite having a partially blocked coronaries. But such a patient, once he starts doing some strenuous physical exercise, right, starts lifting weight, running on the treadmill, right, or hiking, when he starts doing strenuous exercise, then what happens? Myocardial oxygen demand increases. Coronary supply is fixed because orifice decides how much blood can go to the myocardium. So demand increased, supply does not increase. Now what happens? There is ischemia. So once there is ischemia, patient will start experiencing anginal chest pain. But the same patient takes rest. Once he takes rest, myocardial oxygen demand decreased. It back to baseline, and whatever the baseline demand was there, this coronary was able to supply. So now there is a match between the demand and supply. So what will happen to the chest pain? That will disappear, right? So this is the milder end of a ischemic heart disease. Now what do we call this condition as? Stable angina, right? We will call the condition as stable angina. Now what are the characteristics of this stable angina? In a patient with stable angina, the myocardial oxygen demand is met during rest, right? How much ever blood supply your myocardium needs, as long as you are in resting condition or doing basic physical activities, it is met. But once you do physical exertion or you go through some stressful phase, myocardial oxygen demand increases. That will not be met by this blocked coronary. That will not be met by the blocked coronary, and you will experience the ischemia. Right. So now tell me, do you have chest pain at rest in case of stable angina? No, right? Because at rest, whatever is your myocardial oxygen demand, that is being met. So you don't have the chest pain at rest. But during exertion, it appears. Because during exertion, myocardial oxygen demand increases. Now this extra demand cannot be met by the blocked blood vessel. A healthy normal blood vessel can meet that extra demand. But a blocked blood vessel may not be able to meet, so you will start experiencing chest pain. So in stable angina, chest pain appears only on exertion. That is the first and the most important point. It is not there at rest. Okay. And then once he takes the rest, the myocardial oxygen demand is now again met. So what will happen to the chest pain? It will disappear, right? So chest pain relieves on taking rest, or instead of taking rest, if I give a nitrate, what is nitrate? Nitrates cause vasodilatation. So now I have a blocked coronary artery, right? But if I give a nitrate, the coronary vessel becomes dilated. So even if there is a small block, I may be able to give blood supply because the coronary artery is dilated, right? This is an artery, there is a partial block, but if I dilate the artery, then the lumen increases and the blood flow increases. So that can also relieve the chest pain. So chest pain gets relieved on rest or taking sublingual nitrate. Why are we choosing the sublingual? Because that is the fastest route of onset of action. Sublingual nitrates within a period of 5 minutes. Within a period of 5 minutes. This is the classical definition of stable angina. An anginal chest pain, which is retrosternal squeezing type, referred to the both shoulders, jaws, neck, epigastrium, which appears only on exertion and is promptly relieved by taking rest or sublingual nitrates within 5 minutes. So simple example is the patient says that, sir, I climb one floor, I go to the first floor, I start experiencing the chest pain. I sit down, I relax for 2-3 minutes, the chest pain disappears. Then I again climb to the next floor, chest pain appears. I sit down, within 2-3 minutes, chest pain disappears. Then again I climb, and this is how I reach my apartment in the 3rd floor. That is the usual story. Or the patient would say, sir, I can walk 60-70 meters and then the chest pain appears. I have to sit, take 2 to 3 minutes of rest. Then I feel better and then I can walk another 50-60 minutes. So chest pain only on exertion and promptly relieved by rest or sublingual nitrates. That is stable angina. Okay. Now what is unstable angina? Unstable angina refers to the condition which, like, to call it a stable angina, angina should meet all these parameters. Means only on exertion and relieved by rest or nitrates within 5 minutes. If any of these parameters are breached, then it is unstable angina. So to give you an example, angina that started at rest only, right? Now I'm taking class, I'm talking to you, and then all of a sudden I start experiencing an anginal chest pain. I'm not doing any major physical activity, I'm not exerting myself, and I start experiencing typical anginal chest pain. Then it is unstable angina, right? Angina, that is angina originating at rest. Second, I have another patient whose angina started on exertion. Like, okay, he started climbing the floors, he reached the 2nd floor and then the chest pain started. He took rest, right? To call it a stable angina, within 5 minutes of taking rest, it should disappear. Now it is 10 minutes and his chest pain is still not improved. Then again it will become unstable angina. Or he has taken a sublingual nitrate, it is more than 5 minutes, it is still not improved. Then it will become unstable angina, right? So the second thing is angina not relieved by rest or nitrates. Rest or nitrates within 5 minutes. We will count it as unstable angina. Okay. So now between these two, which one is a medical emergency? Unstable angina means at rest, how much ever blood supply your myocardium needs, it is not being met. The demand is not being met by the coronary supply. So if I don't reverse this demand supply mismatch, then the myocardium will start dying. So this patient either he would have already developed an infarct or he is on the way to develop an infarct. On the other hand, a stable angina patient, as long as he doesn't push himself too much, doesn't do too much of physical exertion, and he knows that, okay, once a chest pain appears, I need to take the rest, he's relatively safe, right? So stable angina simply indicates that patient has got ischemia. Unstable angina indicates that patient most likely has either myocardial infarction or he is on the verge of developing an infarction. So unstable angina indicates three possible medical emergencies. The first one is what we call as ST elevation MI or STEMI. Okay, that is the most critical myocardial ischemia. The second one is called as non-ST elevation MI. And when I say MI, we know that there is myocardial infarction, the tissue is dead, right? The third, if both of these are ruled out, then there is a possibility of simple unstable angina. Now, all these are considered as medical emergencies because the patient might have presented at just unstable angina, but if not recognized, he may progress to NSTEMI or STEMI, right? So, all these three conditions we call it as acute coronary syndromes. Acute coronary syndromes. Now we will understand the little bit of basic pathophysiology behind that. So in stable angina, what happens? Your myocardium needs some amount of blood supply. As long as you are in rest, the blocked coronary is able to give the required supply. But once you start doing exertion, the blocked coronary is not able to give that extra supply that myocardium needs, and that is why you experience a chest pain. You can quickly come out of it by taking rest or taking a sublingual nitrate. But if my coronary gets little more occluded, right, if it gets little more occluded, now there is further reduction in the blood supply to the myocardium. Okay. Now at this point of time, because the demand of the myocardium at rest may not be met, I might start experiencing the chest pain at rest itself. Okay. If I address it, fine. If I don't address it, slowly the myocardium will start dying or getting infarcted. So I have one question. When the myocardium dies, right, I will show you two markings. You should tell from which side it will die first. This side, the pink side, or the green side. From which side the myocardium will get infarcted first if the coronary artery is critically occluded. Is it the pink one is where you are expected to see the infarction, or is it the green area where you will expect to see an infarction? Pink, right? Because this is the coronary, the blood is moving from the coronary towards the endocardial side. So obviously this area is the one which will be first deprived of the blood supply. So this is the one which will develop an infarction. If I don't correct it, then this area will also become infarcted. So whatever that first I develop, this infarction we call it as subendocardial infarction. We call this infarction as subendocardial. Why are we calling it a subendocardial? Because this is where I have the endocardium, right? Just underneath it, a small thickness of the myocardium has become infarcted. Subendocardial infarction. Now, what is the story? This patient will have the unstable angina as a clinical presenting symptom. And if I do the ECG, I will not see ST elevation. Why? Because for me to see ST elevation, the whole thickness of the myocardium should be infarcted. So when the whole thickness of the myocardium is infarcted, we call it as transmural infarction. Only then I will see ST elevation. So when I have subendocardial infarction, I will not see ST elevation, but infarction to hai, right? This area is infarcted. This is what we call as non-ST elevation MI. Non-ST elevation MI, right? So what non-ST elevation MI indicates? It indicates subendocardial infarction. Subendocardial infarction. Then how will I get to know that this patient has got subendocardial infarction? ECG में तो ST elevation नहीं दिखेगा. For that reason only we have cardiac biomarkers like CKMB or troponin, which will help us to identify whether a patient has got non-ST elevation myocardial infarction. If I don't treat it at this point of time, right? So with the passage of time, even the rest of the myocardium will get infarcted. Now the whole thickness of the myocardium is infarcted, and this is what we call as transmural infarction. Entire thickness of the myocardium infarcted. So once the transmural infarction happens, then ST elevation will be visible on the ECG. So whenever I see ST elevation on the ECG, I know that there is transmural infarction. Whole thickness of the myocardium is infarcted. Transmural infarction. Okay, so now you tell me, between the three conditions of unstable angina presentation, in one there is critical ischemia, myocardium is not dead yet, right? At rest, sufficient blood supply is not there. That is why the patient is having rest chest pain, but myocardium is not dead yet. That is unstable angina. In STEMI, partial thickness of the myocardium is infarcted towards the subendocardial side. That is why called as subendocardial infarction, and the diagnosis would be non-ST elevation MI because ECG doesn't show it. STEMI, the whole thickness of the myocardium is gone. So between the three, which one is the biggest medical emergency, or which one is more critical? Bharti Soni, as long as you have the FMG exam far away, you can continue with me. Otherwise, I have done the revision sessions and you can go through that, because this is a bit more detailed and starting from the ground up may not be suitable for the exam going students. Right. So STEMI is the critical emergency, followed by non-ST elevation MI, followed by unstable angina. All three are medical emergency. Right. As a doctor, I will be happy if I see a patient with simple unstable angina, not complicated by infarction, because I can literally salvage the whole myocardium. If I see the patient with non-ST elevation MI, then some portion is infarcted, I can save the remaining portion of the myocardium by opening this blocked blood vessel. If I see a patient with STEMI, then entire thickness of the myocardium is infarcted, I can only salvage the rest of the myocardium from being infarcted. Right? So that is why whenever we have a patient with STEMI, the go-to treatment is angioplasty. If not possible, then we have to go for the thrombolysis. But whenever I see a patient with simple unstable angina, not complicated by infarction, we treat them with simple anticoagulation. Right? Anticoagulate so that whatever clot that is there does not propagate to become more critical block and thus end up with an infarction. Yes, it is still an acute coronary syndrome. So that is why whenever we have a patient with chest pain, we have to, first thing we have to do is whether it is stable angina or unstable angina. Right? So if it is stable angina, then it is not a medical emergency. So in that cases, we treat them with the drugs like beta blockers or nitrates or calcium channel blockers as vasodilators, and then we will evaluate whether we need to do anything more for the patient apart from giving antiplatelets to prevent developing an MI. But if it is an unstable angina, it is always considered as an acute coronary syndrome, and I need to differentiate between the three. How do I differentiate? Step number one, do the ECG. If the ECG shows that this is STEMI, then we know it is STEMI. Go for the reperfusion, either do angioplasty. If angioplasty is not feasible, then thrombolysis. If I don't see the ST elevation on the ECG, then I will rely on the cardiac biomarkers, that is troponin or CKMB, and as you know, troponin is a preferred one. If troponin is positive or elevated, then that means there is infarction. So then I will call it as non-ST elevation MI. If troponins are not elevated, then it's a case of unstable angina. But all three are medical emergencies. According to the most latest AHA guidelines, it is still considered as part of acute coronary syndrome. Okay. Now, once I have concluded that whatever I am dealing with is a case of angina pectoris and it is unstable angina, because my real fear is an unstable angina patient, maybe a simple unstable angina, NSTEMI or STEMI, and I don't want to miss any of these three cases. Right? So how do I investigate further? The investigations that are required is first ECG. What ECG will help? To identify ST elevation, right? To identify ST elevation. If there is a typical ST elevation present, then it is a case of STEMI. If ST elevation is not there, it still does not rule out infarction. I need to go for the cardiac markers. Cardiac markers. In biochemistry, you people might have studied a lot about cardiac markers, right? Which one is the earliest to rise, right? Which one is the most commonly performed cardiac marker? In clinical practice, most commonly performed cardiac marker is the cardiac troponins. Cardiac troponins. Though in the recent times we have come out with some more advanced biomarkers like ischemia modified albumin and heart type fatty acid binding proteins, they are still not part of the common practice. If specifically they ask you in MCQ what is the earliest marker to rise after the myocardial injury, then it is ischemia modified albumin, called as IMA, followed by heart type fatty acid binding protein, followed by your CKMB and troponins together, cardiac troponins almost simultaneously. But in terms of practice, it is the troponins that we routinely do. Okay. What other investigation can help me to identify a patient having an acute myocardial infarction? The echocardiography. How echocardiography will help me? Echocardiography, I can directly see the contraction of the ventricles. If any part of the ventricle is not getting sufficient blood supply or it is already infarcted, will it be able to contract? A dead muscle, will it be able to contract? No, right? So I can clearly see a non-contractile part of the myocardial wall if there is infarction. So we call that non-contractile part as the regional wall motion abnormality. Regional wall motion abnormality. So these are the points which can help me to quickly identify an infarcted myocardium. If there is ST elevation on the ECG, or if there are elevated cardiac troponins, or if I see regional wall motion abnormality. Okay. But in more modern medical practice, it is not based on human assumptions, right? Okay, हाँ, for me looking at the history and the parameter, मुझे लगता है कि हाँ ये cardiac chest pain है, मुझे लगता है कि शायद ये cardiac chest pain नहीं है. That is thing of the past. So what is currently recommended is a more protocolized, like doctors भी robot के जैसे ही काम करना पड़ता है, so that we don't miss out on taking actions whenever possible, because ultimately we are humans. So there are scores to guide us whether this is likely to be a cardiac chest pain or the non-cardiac chest pain. What are those scores called as? There are two important scores for us to understand. One of them is called as heart score, and the second one is called as EDAC score, heart score and EDAC score. So whenever you have a patient with chest pain in the emergency room, whatever we have learned so far, that can definitely help you to gauge कि हाँ ये शायद cardiac chest pain हो सकता है या शायद non cardiac हो सकता है, और अगर cardiac है तो क्या ये pericarditis की वजह से है या ischemic वजह से है, मतलब angina है, and if it is angina, whether it is stable angina or unstable angina, that much we can distinguish based on whatever we have learned so far, right? But please don't trust your instincts, don't trust your own knowledge when it comes to chest pain, because missing out an ischemic chest pain can be catastrophic to anybody's career and life, for patient's life as well as the doctor's life, right? So follow more guidelines, stick to the protocols. So protocols क्या कहता है? Whenever you have a patient with acute chest pain, you can use your clinical knowledge to gauge कि हाँ शायद ये cardiac chest pain है, but be firm only when you have applied these scores. Two scores are there, one is heart score and the other one is EDAC score. In India, because we follow more of the American medicine, we follow the heart score. Heart itself is the mnemonic here. Heart, H stands for history, E stands for ECG, A stands for age of the patient, R stands for presence of the risk factors for coronary artery disease like hypertension, dyslipidemia, right? And the T here stands for the cardiac troponins. Calculate the heart score. Once we have calculated the heart score, a score of 0 to 3 means you have low risk of having the myocardial ischemia. And a score of 4 or more than 4 means very high risk of myocardial ischemia. Yes, myoglobin can also be elevated after myocardial injury, but as a doctor, I don't consider it as a marker of myocardial injury at all. In physiology and in biochemistry, you may study about it, but in clinical practice, it is irrelevant. Why? Because you go to gym, lift some dumbbells, and then your myoglobin level will be elevated, because myoglobin is not selective to myocardium. It is non-specific. It is there in your skeletal muscles, smooth muscles, as well as myocardial cells, right? So even when strenuous exercise, which would have caused or triggered a chest pain, that strenuous exercise itself could have caused myoglobin to get elevated, right? So we don't use it in practice. So troponin T and I do not have a major difference, except that their duration of being elevated, the time taken for them to return to the baseline. That's the only difference. Otherwise they peak almost at the same time, but the time that they return to baseline is slightly different. Now, having understood that we have to apply the heart score and what is counted as not low risk, we'll see how the American Heart Association guidelines recommend or suggest us to approach a patient presenting with acute chest pain using this heart score. As we know, any patient presenting with acute chest pain, don't trust your instinct. Go ahead and do the basic workup. ECG is the bare minimum thing that I would do. When I get an ECG done and it shows ST elevation, right, then the diagnosis is clear. It is ST elevation MI. And as per the guidelines, we will treat the patient as ST elevation MI. Guidelines, what they say, the treatment of choice is percutaneous transluminal coronary angioplasty. Angioplasty is the treatment of choice. Okay. If ECG does not show the typical ST elevation, but some कुछ changes which makes me think it could be still ischemic, मतलब non ST elevation MI हो सकता है. In such cases, we will further look at the cardiac troponin, right? But if ECG turns out to be fully normal, the story does not end there. This is a common mistake that we do, right? हाँ, patient complaining of chest pain, ECG किया, turned out to be normal, चलो घर भेज दो, कुछ प्रॉब्लम नहीं है, राइट? रीएश्योर किया, हाँ सब कुछ ठीक है, आपका हार्ट ठीक है, एंड सेंड होम. बिग मिस्टेक. इवन इफ ECG turns out to be normal, we have further steps to take. If the patient has a known coronary artery disease, मतलब previously documented MI है, a known chronic IHD है, in that case, look at the troponin again. Even if patient ECG turns out to be normal and he does not have an established or a known coronary artery disease, even then you cannot dispose the case of as saying that this is not cardiac in nature. That is where we have to apply the heart score. Right, I just showed you the heart score, and heart score 0 to 3 is counted as low risk, and when it is 4 or more than 4, it is not low risk at all, right? So in a patient who presented with acute chest pain with no ECG changes and no background history of having coronary artery disease, I calculate the heart score, and if the heart score is 4 or more than 4, right, my next decision will be based on the troponin. But now just look at the other side of the flow chart. Even if my heart score is 0 to 3, we just counted according to Harrison that it is low risk. But what American Heart Association recommends, even if you have a patient who presented with acute chest pain, whose ECG is normal, he does not have the past history of a coronary artery disease, and his heart score is 0 to 3. We have to do serial troponins. When I say serial, that means not a single troponin level. You have to do multiple troponins. Right? At an interval of 30 minutes to 1 hour, you have to do at least 2 to 3 troponins. So if you do serial troponins and they also come negative, then you can discharge the patient saying that this is non-cardiac chest pain. So please keep a mental flow in mind. A patient presented to the emergency room with chest pain. You spend 1 minute to take a quick history. Where is the location? Retrosternal. Where is it getting referred to? Shoulders, neck, jaw, oral cavity, epigastrium. What is the nature? Squeezing or constricting type. When did it start? At rest, or started on exertion, but I have taken nitrates, not relieved, or I have taken rest of 5 minutes, not relieved. That is why I have come to you. Well, all of this is unstable angina on clinical grounds. Right? What is our next step? Do an ECG. If ECG shows ST elevation, diagnosis is done, it is an ST elevation MI, the cardiologist will do the angioplasty. If ECG turns out to be normal, the story is not over. Visit the patient's past history, known coronary artery disease, then again look at the initial troponin levels. But if there is no known coronary artery disease also, please apply the heart score, and if the heart score turns out to be low, even then we have to serially monitor the troponin. So patient has to spend at least 4 to 5 hours in the emergency room or the high dependency unit after presenting with acute chest pain. Right? Only when serial troponins turn negative, you will be considering it as non-cardiac chest pain and you can discharge the patient. In all other circumstances, what we do, if the heart score is 4 or more than 4, right, or if the patient has past history of coronary artery disease, then we will only look at the initial troponin level. Serial is not required. First thing is just look at the initial troponin level. If initial troponin level is elevated, what does that mean? If initial troponin level is elevated, troponin elevation means myocardial ischemia तो हो गया है. ECG में ST elevation नहीं था. So then what is the diagnosis here? The diagnosis will be non-ST elevation MI. Infarction हो गया है, इसीलिए troponin is elevated. So obviously that patient will require the admission to the hospital and then maybe angiography and then eventually further management according to the findings. If the initial troponin in these patients where there is previous history of coronary artery disease or the heart score is more than or equal to 4, even if the initial troponin is negative, we still need to admit them and observe. Clear? This is the approach we need to take. All of us need to by heart this, because every now and then our relatives approach on phone with us saying that I've got chest pain. We might have to direct them appropriately depending on their situation. And once you become an intern and start doing some duties in the emergency room, your PGs or residents may not be readily available on phone call, and sometimes you are pressed to take a quick action. So as long as you know this protocol, you are safe, right? You are safe, and hopefully your patients will be safe, right? This is our approach to a patient presenting with chest pain. Now there are some more questions to address before we wind up. On clinical grounds, how do I differentiate between a chest pain due to acute pericarditis and medlad? No. See, there are certain conditions where the infusion of NTG can be catastrophic. For example, if I have chest pain because of esophageal perforation, what you call as Boerhaave syndrome. Because of perforation, I would have already bled profusely from the site of perforation. I would have lost 500 ml or 600 ml of blood. And now if you give me the NTG, that will cause vasodilatation, that can cause profound hypotension or shock, right? So always making a quick diagnosis. It's not very difficult, right? All you need to do is have a patient with chest pain, spend only 1 minute on taking history, mainly trying to gauge whether it is cardiac or non-cardiac, right? Cardiac, we just learned the characteristic features. So ask the leading questions instead of asking the patient ki haan batao aapki kahani kya hai. No. In the emergency room, it is never about patient revealing. It is about quickly you trying to extract the history, right? Ask chest pain kahan pe hai, where does it get referred to, how does it start, what were we doing when it started, and did you take nitrates or did you take rest and did it relieve? No, you have your answer. You know whether it is stable or unstable angina. Agar unstable angina lag raha hai, then follow the heart pathway, right? Quickly an ECG, ST elevation, STEMI. ST elevation nahi hai, right? But ECG में कुछ changes दिख रहे हैं तो शायद it is non-ST elevation MI. And if ECG is fully normal, even then look at the heart score, follow the pathway that will take you to the diagnosis. Okay. Now this point, how to differentiate between the chest pain of acute pericarditis, which is also kind of acute pain, and the anginal chest pain. This is mainly, see, in the emergency room, it's really not important. Just follow the heart pathway to deal with any patient presenting with acute chest pain. But in bedside discussion, the teachers do ask, how do you differentiate between anginal pain and the chest pain because of acute pericarditis, right? So in terms of comparison, the chest pain of angina and acute pericarditis, right? Both of them, in terms of location, both of them are located to retrosternal region. Both of them are located to retrosternal region. Angina is also retrosternal, pericarditis is also retrosternal, right? But radiation varies. The angina, as I told you, it gets radiated to both the shoulders, arms, neck, jaw, as well as epigastrium, right? On the other hand, the acute pericarditis gets radiated to the back, right? Retrosternal, exactly behind, means interscapular region is where the acute pericarditis pain gets usually referred to or radiated to, right? It gets radiated to back, more precisely interscapular region. Then the pain of angina is usually aggravated by exertion, right? It is usually aggravated by exertion. On the other hand, pain of acute pericarditis gets aggravated by inspiration. It gets aggravated by inspiration. Can anybody tell me why does it get aggravated by inspiration? So please remember, the pain of acute pericarditis is because of the rubbing of two layers of the pericardium. So we know that there are two layers of the pericardium, right? So whatever I have drawn here in black, think of that as the myocardium, okay? So on top of this myocardium, we have one layer of pericardium which is just adherent to the myocardium. We call that as the visceral pericardium. Visceral pericardium. And then separated from the visceral pericardium, we have one more layer of pericardium called as parietal pericardium. Between these two, there is a small amount of fluid, like usually less than 20 ml of fluid is there in the pericardial space. And when left ventricle fills during diastole and expands, and when it contracts, right? So the two layers either come little closer or move apart, but they never come close enough to rub against each other. They never, in a normal cardiac cycle, the two layers of pericardium do not rub against each other. But what if there is pericarditis and these layers become inflamed? So because of inflammation, they become thick, right? The thickness of the inflamed layer increases, and once they increase, the chances that they coming together and rubbing against each other increases, right? And typically what happens during inspiration, we have lungs around this, right? So the lungs are expanding during inspiration. As the air is filling into the lungs are expanding. So the expanding lungs will crush the two layers of pericardium together. So the two layers of the pericardium will come against each other because of the expansion of the lungs, and they will rub against each other, and then that creates the pain. During expiration, what happens? The gas is leaving the lungs, so lungs move apart and the two layers get separated and the pain gets relieved, right? So typically the pain of acute pericarditis is worse on inspiration and it gets relieved on expiration, or it is better on expiration, while the anginal chest pain gets relieved on rest or with the help of nitrates. Nitrates will not be able to relieve the acute pericarditis chest pain. They will only the NSAIDs or anti-inflammatory agents can relieve the chest pain of acute pericarditis. Clear? So first and the most important point that helps you to distinguish between the pain of angina and the pain of pericarditis is the relationship with respiration. And that is why this acute pericarditis type of chest pain is called as pleuritic in nature, right? We call it as pleuritic in nature. It is called as pleuritic because when you have pleuritis, same happens. Two layers of pleura rub against each other. Again, two layers of the pleura are likely to come together and rub against each other during inspiration. So pleuritic chest pain is also worse on inspiration, better on expiration. Pericarditis chest pain also is worse on inspiration and better on expiration, and that is why it is called as pleuritic. And if you have ever experienced pleuritis, you probably know this. When two layers rub against each other, right, it feels like someone is cutting through your tissues. It is a very sharp, penetrating type of chest pain. Sharp, penetrating type of chest pain. On the other hand, this anginal chest pain is more of diffuse, squeezing or constricting type of chest pain. Squeezing or constricting type of chest pain, right? So now you know the basic difference. Another point I forgot to mention. Even the posture has an influence on the pericarditis chest pain. So the chest pain because of angina, whether you're sitting, whether you're lying down, whether you're turned to left, whether you're turned to right, it will still always stay the same. But the chest pain because of the pericarditis, right, generally feels better on sitting up and leaning forward, and it feels worse on lying down. What is the reason for that? The reason is your heart is suspended in the pericardial sac, right? You can think of it like this. This is your heart suspended in the pericardial sac. Okay. So when you sit and upright, the parietal pericardium, which is lining over the myocardium, and the visceral pericardium, which is lining over the myocardium, and the parietal are well separated when you are sitting upright and leaning forward. But when you lie down, because of the gravitation, what happens? This is your pericardial sac, and because of the gravitation, when you lie down, heart starts resting on the pericardial layer. So they come together and rub against each other, and that produces the pain. So pericarditis chest pain is worse on lying down. Worse on lying down. On the other hand, there is no relationship with the position in the anginal chest pain, right? Whether I am sitting, lying down, standing, no matter what position I am, I will have that constant pain going on. But pericarditis, you ask me to lie down, I will experience severe pain. You ask me to sit and lean forward, I will feel the relief. So these points can help us to differentiate between the chest pain because of angina and chest pain because of acute pericarditis. Clear? Okay, so now we will revisit our first scenario. We had two patients, patient A and B. Now many of you have heard from the beginning, so tell me, between A and B, who is more likely to be having acute pericarditis, and who is more likely to be having the angina? For angina, do you think it is A or B? A or B for angina? Right. So this B is more suggestive of angina, right? And these are the patients who are more likely to be ignored by the junior doctors or duty doctors or the peripheral doctors or non-allopathic doctors in clinical settings. And these patients get undue attention. Acute pericarditis, yes, the condition needs to be treated, but it's not a bigger emergency than these patients, right? So I hope we have the clarity now how to differentiate between cardiac origin chest pain and non-cardiac origin chest pain, right? How to differentiate between angina and acute pericarditis, how to differentiate between stable and unstable angina. And every time you have a patient who can be categorized as unstable angina on clinical grounds, how do we apply the heart pathway to take the final decision whether it should be counted as STEMI or NSTEMI or unstable angina or a non-cardiac chest pain and discharge. I will leave you with some of the MCQs in the notes. Please solve them, because one of the common template of MCQs that has emerged in the recent times, especially when these clinically oriented questions started coming up, is they give you the story of a patient with chest pain, and then they will ask you something related to the management, right? Whether you will send him home, whether you will admit and do angioplasty or thrombolysis, whether you will give anticoagulants or just start on antiplatelets. And to be able to answer that, you have to come to the mental conclusion that whether it is pericarditis, non-cardiac chest pain or anginal chest pain, and if it is anginal, should I consider it as stable, unstable, and if it is unstable, should I consider it as just unstable angina or NSTEMI or STEMI, right? So if you solve those MCQs, hopefully that will help. Okay, so we will be discussing the acute coronary syndrome again in a separate module, but I will give you a quick idea why we don't do the thrombolysis. See, basically in STEMI, there is a fully formed thrombus almost causing critical or 90% plus occlusion of the coronary artery that needs to be dissolved completely and quickly, right? Or it should be removed through angioplasty. In the NSTEMI, what happens? It is not such a critical situation that I need to act quickly, first thing. And second, in NSTEMI, primarily what is happening is you have a coronary artery in which you have a clot, or you have a atherosclerotic plaque. So think of this as the cholesterol deposit or atherosclerotic plaque. Now this plaque has ruptured. So when the plaque gets ruptured, right, you have this endothelium lining here. So when the plaque gets ruptured, there is a minor injury to the endothelium. So there is a minor injury to the endothelium. And you might have studied about what is called as Virchow's triad, right? Virchow's triad. What does that say? Virchow's triad. See, if this is a coronary artery which is critically occluded with a thrombus, then I would have got the transmural infarction, that is STEMI. This thrombus needs to be taken out, right? Either by angioplasty or thrombolysis, and because studies have shown that angioplasty is better, we go ahead with that. But here what has happened, there is a atherosclerotic plaque which has ruptured. The rupture has resulted in endothelial injury, and the Virchow's triad says endothelial injury, stasis of blood and hypercoagulability. These are the three important risk factors for initiation of a clot. So now that I have endothelial injury, the coagulation cascade will be activated. Endothelial injury will expose von Willebrand factor, right? That will trigger platelet plug formation, and then eventually we will activate the coagulation cascade and we start developing a clot. So a clot is about to start forming here. So what is my priority here? Is it to clear this atheromatous plaque or to prevent the clot from forming the site of endothelial injury? It is the prevention of clot formation. How can I prevent? By giving anticoagulants. That is why the mainstay of treatment for the non-ST elevation acute coronary syndromes, simple unstable angina as well as NSTEMI, is to start with the heparin or other rapid acting anticoagulants. Once you give the anticoagulants, one problem is solved, that you have prevented the clot propagation. Now you can take your little time and then clear this atheromatous plaque and then put a stent here. So in NSTEMI also we do angioplasty, but not on an emergency basis, because it is not completely occluded, and we can easily prevent a clot formation. The role of thrombolysis doesn't come into picture because you don't have a full formed thrombus yet, right? So you are preventing a thrombus formation. In case of the STEMI, there is a full formed thrombus near total occlusion of the artery, so we need to dissolve that thrombus. That's the basic difference. So that's the important point for you to remember. In terms of treatment, for NSTEMI, step number 1 would be to give anticoagulation, and then depending on the criticality of the situation, either within 24 hours or within next 2 hours, you have to do the angioplasty. Patients who are unstable require angioplasty within 2 hours. Stable patients, you can do angioplasty within next 24 hours. But if it is STEMI, that means there is a full formed thrombus, right? So you have to either go ahead with directly angioplasty, and if angioplasty is not feasible, then you have to consider thrombolysis. Because there is already a clot which is formed. In NSTEMI, a clot is just forming, or it is just being activated. A coagulation cascade is just being activated. That is why we would rather try to prevent that clot from forming by giving the anticoagulants. That's the main difference. And if there is no clot, there is no role of thrombolysis yet. Clear? Okay, so please solve those MCQs, and then we will continue discussing in the next session with other cardinal topics from the Harrison. Okay, so see you soon guys. Till then, have a good time. Bye-bye.